welcome everybody, and welcome to this first episode of the Statistical Corner. I would like to spend just 1 minute in presenting this new format that we all together in this young board we decided to do and to present to all the young fellows to give a deep dive into the statistical method of a paper and to explain to young fellows and young interventional cardiologists how to interpret statistics in a paper, because every time, as we know, when we read an article, we always jump most of the time to the results, to the discussion part, and the statistical part is always jumped. But we believe that it's very important, first of all, for academic interest to know how to do a statistical analysis, but especially to know how to interpret a trial or a study and to understand really the results. So today we are going to present a randomized control trial. Go to the first slide. Alice Benedetti will be the host, will be the young reviewer who is going to present the trial. And we have the honor to have here for our first episode Professor Giuseppe Biondi-Zoccai, who everybody here knows as one of the leader interventional cardiologists and the statistics guru in Italy and also in the world. And I would like also to personally thank him to the help he gave us in organizing this new format that we will go in parallel with the clinical corner. So today we're going to focus on randomized control trial, and we are going to focus on the SMART trial in the statistics method. The SMART trial, as we know, compared self-expanding and balloon expandable transcatheter aortic valve replacement in patients specifically with small aortic annulus. And as we can see, there was no difference in the primary endpoint between the two interventions. But however, there was a significant difference in bioprosthetic valve dysfunction because balloon expandable valves performed less than self-expandable valve. So if you want to go, Alice, and present.
Yes, thank you, Francesco, and thank you for introducing this first episode of the Statistical Corner from Gise Young. As you said, we're gonna talk today about the SMART trial. Specifically, we're going to focus on the statistical analysis performed to assess the two co-primary endpoints of the trial. So the SMART trial is a prospective randomized control trial. It was conducted at 83 international sites, and it included all-comer patients with a symptomatic severe aortic valve stenosis and a small aortic valve annulus, defined as an aortic valve annulus area below 430 millimeters squared, assessed on CT scan. All patients enrolled were randomly assessed in a 1-to-1 ratio to receive a self-expanding balloon valve or a balloon expandable valve. And the two co-primary endpoints at 1 year follow-up were the first one, a clinical outcome co-primary endpoint, a composite of mortality, stroke, or heart failure hospitalization. And the second one was a co-primary endpoint to assess the bioprosthetic valve dysfunction. So after the randomization, the intention to treat population consisted of 366 patients in the self-expanding valve group and 371 patients in the balloon expandable valve group, while the implanted population consisted of 350 patients for the self-expanding valve group and 365 for the balloon expandable valve group after the crossovers. So it is important to highlight that the clinical outcome endpoint was evaluated in the as-treated population. So the population in which a procedural attempt was performed, while the valve dysfunction endpoint was evaluated in the implanted population. So the population who successfully was implanted with a bioprosthetic valve. But let's go deeper in the statistical analysis performed to assess these two co-primary endpoints. So the first one, the clinical outcome. As we just said, it was assessed in the S-treated population, and the treatment effect was summarized as a risk difference at 1 year follow-up with a 90% confidence interval. It was evaluated for non-inferiority of self-expanding valve to the balloon expandable valve with a one-side alpha of 0.05 and a non-inferiority margin of 8% event rate. In this case, under the assumption of 60% event rate in each group, it was computed a sample size of 700 participants to provide an 85% power for this. So for the second co-primary endpoint, the bioprosthetic valve dysfunction, it was assessed in this case in the implanted population, and the treatment effect was summarized as the risk difference with a 95% confidence interval. And this endpoint was evaluated for superiority of self-expanding valve to balloon expandable valve with a one-side alpha of 0.025. In this case, it was assumed that 40% event rate for self-expanding valve and 36% event rate for balloon expandable valve with a sample size of 120 participants would provide 80% power for this second co-primary endpoint. So let's have a look at the results presented in this trial for the first co-primary endpoint, the clinical outcome. In this case, the Kaplan-Meier estimate of the event rate was 9.4% for the self-expanding valve group versus 10.6% for the balloon expandable valve group, with a risk difference of minus 1.2% and a 90% confidence interval, which with the upper limit is below the 80% margin. In this case, so the non-inferiority of the self-expanding valve versus the balloon expandable valve was met. For the second co-primary endpoint, the bioprosthetic valve dysfunction, it was also in this case assessed with the Kaplan-Meier analysis, and the estimate rate of events resulted 9.4% for the self-expanding valve versus 41.6% for the balloon expandable valve, with a risk difference of minus 32.2% and the 95% confidence interval, which does not include zero. So for the superiority of the self-expanding valve versus the balloon expandable valve was met. So now let's ask to our experts some insights to better evaluate the statistical analysis performed to assess these two co-primary endpoints. So Francesco, would you like to ask some questions to Professor Biondi-Zoccai?
Yeah, thanks, Alice. So as every time when we read a paper, we finished it, and if we read the statistical analysis, we have thousands of questions. So now we have the opportunity with this new format to have some insights, specific insights on the statistical analysis. So I think that the first thing we would like to focus on is on our statistical focus is the power. So Giuseppe, can you tell us something about power and alpha and beta?
Yes, many thanks for this opportunity. Basically, whenever you design a study, you want to minimize the chances that your study is not informative, is irrelevant, and thus this for practical reasons and also for ethical reasons. And so you need to be able to aim for a reasonably precise eventual effect estimate. And this can be measured a priori by computing the power of the study you are designing. And basically the power can be, put into a perspective similar to a diagnostic test, for instance, to recognize coronary artery disease. You basically have a 2x2 table in which you have different scenarios you have a true difference between the treatments and you find it, correct inference. You have a true difference between the studies, between the treatments, and you cannot find it. So it's a type 2 error measured by beta. You don't have any difference, and you actually demonstrate there is no difference, which is 1 minus alpha, and you basically have no difference, and you cannot claim it. Basically, I think I lost myself in the table, but the key point is that you need to minimize alpha and you need to maximize beta. And thus, you need to find something which is meaningful for your decision making. The key point in this study, which is quite complex, is that they aimed for two concomitant goals. One was demonstrating non-inferiority for a clinical endpoint, and one was showing superiority for a surrogate endpoint. Why so? Because 700 patients would have been too little to demonstrate any superiority, assuming there is any, on a clinical endpoint. Okay, please go on.
Yeah, so
yeah.
The second part is about, as we say, non-inferiority and superiority. So can you explain us how it's calculated and how we can
Basically, it's a simple mathematical formula. So you have a formula in which you enter some factors and you end up with a result. Imagine epsilon equals A plus B plus C and so forth. The key point, most of these factors, you assume them from your prior knowledge or prior studies or from a pilot study. The key point is that basically the power of a superiority or non-inferiority study boils down to how much narrow you want your confidence interval to be. And here it is shown by these blue and red bars. The subtlety is that typically in a superiority study, you have a two-tailed 95% confidence interval. And indeed, in this study, they claimed it was one-tailed 97.5%, but it's the same thing. Whereas for a non-inferiority, you aim for a one-tailed. So the key point, though, is to maximizing the informativeness of your estimate, and the informativeness of your estimate depends on the width of the confidence interval. Remember that the confidence interval and the p-value go hand in hand, and so a lower p-value means that the confidence interval is more narrow for a superiority design, or is farther away from your non-equivalence threshold for a non-inferiority study. Please.
Okay, yeah.
And in this case, for the superiority test, basically they had a very precise effect estimate for bioprosthetic wall dysfunction, and you can see that the null effect is 0, the point effect estimate is minus 32%, the confidence interval is very, very far from the 0, and thus the p-value basically amounts to the distance between the rightmost border of the red confidence interval from the 0. The key point is that you need to be able to demonstrate an effect, and this effect could be either that your device is superior for a dimension, or your device is reasonably similar to another device or another intervention.
Okay. Prof, I have one question. Could you please explain us what does it mean, the inferiority margin, and how did the authors set this cutoff of 8%?
So this is basically a choice based on some guidances, for instance, from the FDA or from EMA or from your clinical judgment. Of course, I'm a fan of meta-analysis, and from a meta-analytic perspective, non-inferiority is not meaningful because it's something that has a meaning only for a given study, but cannot be extrapolated to a multitude of studies. The key point is that imagine that I want to bring you to dinner to my favorite place in Rome, which is a restaurant called Zingarella, close to San Giovanni Hospital. However, it's very far, and I give Zingarella Amatriciana a 10 because they actually come from Amatrice, which is in Abruzzo. So basically, Amatriciana is an Abruzzese dish. But the key point is, you tell me it's too far. Let's go to a nearby place, and I tell you, okay, for me, I can eat a Matriciana only from 7 above. So my non-inferiority margin will be a delta of 3. Okay, this is meaningful because I don't want you to bring I don't want to bring you to dinner to a place which has an Amatriciana 6 or low in quality, like a Chinese restaurant. But 7 or more is fine. If we find 9, it's perfect. If we find 10, I don't believe it, but it's possible. So the key point is that, and of course, it's a pretension. It's a way of pretending in a way. It has more meaning for a quantitative estimate. I give you an example. It's more meaningful if you want to introduce a new blood pressure lowering agent. You know, a generic of, say, amlodipine, and you know amlodipine 1 milligram decreases blood pressure by 5 millimeters, you accept that the new generic decreases amlodipine blood pressure by 4, at least. For clinical events, it is debatable ethically because 8% is very big in many ways.
Mm-hmm. Thank you. So let's go to our conclusion after the review of this clinical trial. So in our opinion, the strength of the trial is that an appropriate sample size for both co-primary endpoints, the non-inferiority of the self-expanding to the balloon expandable valve was met for the clinical outcome endpoint, and the superiority of SEV to BEV was met. What about the limitation? There was a lower event rate than the assumed event rate for the clinical outcome endpoint, 60% versus 10%. It was a 90% confidence interval evaluated for the clinical outcome endpoint, and a non-inferiority margin of 8%. And then the Kaplan-Meier estimation of the event rate. What do you think, Prof, about the Kaplan-Meier estimation?
We cannot hear you.
My fault. I think the Kaplan-Meier is very nice. If you go to the actual study, figure 1A, it's nice. I think it's worth perusing attentively because they do a number of good things. First, they put patients at risk. Okay. If you can go back, can you go?
Yes.
Just because I think this is a very, very key important point for your whenever you do a study or you publish a study with a Kaplan-Meier, you know, one good thing they do is they put patients at risk. And another thing they do very nicely, it's shown in the article, actually, not here. They present both the magnified picture as you are showing it, as well as the picture with the y-axis, which goes from 100 to 0. Okay, you
Yeah.
can see it in the paper.
Yeah.
They do one wrong thing, though. They don't put confidence intervals into the graph. So the key point of the Kaplan-Meier, whenever you look at one, imagine that the lines you are looking at, they are not real. They are just an average. So imagine that
Yeah.
the Kaplan-Meier is me shooting with a rifle, but I've suffered from Parkinson's disease, and I'm actually shooting in a in a range. And so basically the two curves impose one over the other. But I think it's very clearly showing that the two treatments are very similar. And if they had tried to demonstrate superiority here, they would have needed maybe 50,000 patients.
Okay. Thank you, Prof. So, Francesco, let's see if we have some question
Yeah,
from the
we
audience.
have a lot of questions in the chat. So the first one is when and how do you choose when it's better to go for superiority or non-inferiority in a trial?
You know, it's the important preamble I want to give you is once I was reviewing a paper, revising a paper for JAM. I don't remember. It was a very complex analysis, and we had a very professional statistician, and I asked him an advice, and he told me, I don't know. I'm not an expert in that specific area. So it's difficult to find an expertise in everything. So work on specific items step by step. The choice of superiority or non-inferiority, it boils down to your clinical judgment. So if you believe a treatment is better than another, then aim for superiority. If you believe that the treatment is similar, then don't fool yourself and go for non-inferiority. You might, though, as they did here, aim for non-inferiority or superiority for a surrogate. Basically, what they did here, and this is a very nice example, and I thank you for this, is that they did two trials at the same time. They could have published a non-inferiority study without any superiority goal, or they could have published a superiority study for a surrogate without any non-inferiority goal. In my opinion, you know, if you have a breakthrough intervention like Cribier 20 years ago, you can go for superiority. If you have a Me-Too valve, like, you know, many new TAVI devices today, just aim for non-inferiority and it's fine, as long as you have a lower price or lower sheath and so forth.
Thank you very much, Giuseppe. And another very important question, I believe, is that is very practical, is actually how do you practically calculate the sample size? Is there any website or which advice can you give to some young fellows you want to do like to start to design a randomized control trial?
There are a lot of nice websites. For instance, there is a website called Sealed Envelopes, which is very, very nice. My recommendation, though, is to go either to R or Stata and create a query, create a syntax, sorry. You can create it by copying and pasting similar syntax examples, or you can ask ChatGPT to generate a syntax. And then you know, save the syntax. Basically, it's an equation from the high school. So you have a bunch of factors and you end up with your results. I think syntax in R or Stata is better because then you can copy and paste it and show that you have actually done it in a way that can be reproduced.
Okay, thank you very much. And another question from Giulia Masiero. What about the impact of the difference between the estimated rate and the actual rate? Is this something that we need to take in account when we look into trial?
Yes, this is important because typically when we design a trial, we overestimate effects. We are over-optimistic, and this may create big disappointments. My recommendation is to to be to share decision making and include somebody who's skeptical. And remember that you need to be aware that most trials today are underpowered. It's very unlikely that you do a very powered study unless you put in the primary endpoint surrogates, and those surrogates are not very informative. I'll be very brutal. Even repeat revascularization in the modern era is just a surrogate. And if you want to demonstrate a benefit on death or MI, it's almost impossible with current scenarios. So don't overestimate. Be objective and aim for non-inferiority if you cannot aim for superiority.
Okay, and the last question, then unfortunately we have to close, is intention to treat versus treated population. How does it affect non-inferiority interpretation, especially when crossover rates is high, by Giorgio Benatti?
Yes, this is a nice question which could be used for a university test. So basically, when you do a randomized trial, you need to go for intention to treat, because if you go for as treated, you create a lot of distortion, especially when you can guess the intervention, for instance, in a study where there is no placebo. So in this trial, they could have chosen a given device in patients with small femoral arteries, and this could have created a distortion. When you aim for a non-inferiority or equivalence, you need to make sure that there was not too much crossover or distortion from the randomization, because if I'm giving you something which is not effective by randomization allocation, but you end up using something else, I could infer non-inferiority while indeed the new treatment is inferior. But the key point, don't let anybody distort the randomization allocation code, because even if you find that with the treated or the intention to treat, you don't have many differences. But if there is a high rate of non-adherence to the intention to treat, basically your trial is no longer a randomized trial, and you won't be able to convince anybody with its results.
Okay, thank you very much. I think that it would be a really, really important talk today. Thank you, Alice, for the presentation, and really a really big thank you to Giuseppe for
Thank you very much.
And is a really clear explanation of a really difficult concept. So we will organize in some weeks the second episode. It will be probably we will discuss about the topic. It will be or either about randomized control trial or either about observational trial, but we will keep you updated. And thank you very much to everybody, because we know that digest statistics at 7:30 in the morning on Friday is very difficult. Yes. But we had very important attendance at the meeting. So really, thank you very much to everybody, and we'll see soon.
Thank you.
Bye.
Bye.
Thank you.
Thank you. Bye-bye. Very
Bye.
nice meeting. Bye-bye.
Bye.